Great. Good. Can you hear me okay? Yeah, great. So welcome everyone to day 2 of the conference. I hope you had a brilliant first day and are ready and energized for day 2. Before I introduce our keynote speakers, just one small request to please vote for the posters on Padlet. We'll be having the poster awards at the end of today, so your votes will help us in terms of identifying which posters to award. So it's my pleasure to kick off today with introducing this morning's keynote speakers, my colleagues, Professor Lucie Byrne-Davis and Professor Joe Hart. So Lucie is Professor of Health Psychology, and Joe is a Professor of Health Professional Education and the Head of Division of Medical Education, quite a mouthful. Both are based at the University of Manchester in the United Kingdom, where they jointly lead the Health Workforce Research Group. I know a joint keynote might seem like a less typical format, but Lucie and Joe are truly a dream team. Each has too many personal achievements and accolades to list, including prestigious fellowships and chairs of professional societies. But in my opinion, they are a living example of what working together can help achieve. Their research and practice focuses on translating health psychology to support behavior change, with a focus on healthcare professional behaviors on topics such as combating antimicrobial resistance. They have been key figures in helping to advance both the science and practice of behavior change, but with an emphasis on translation of academic methods, evidence, and theories into policy and practice across the world. Indeed, every time I speak to Lucie and Joe, they seem to start the conversation with a comment about the last country they have just arrived back from. One week it might be Egypt, the next it might be Uganda. I think you're off to Saudi Arabia next week. So they are really leading efforts to build capacity in behavior change globally. Indeed, they co-founded the Change Exchange, an internationally renowned collaborative of health psychology professionals who work to understand, drive, and evaluate behavior change within health partnerships between the UK and health organizations in LMICs. And lastly, on a more personal note, I can testify to the fact that not only are they brilliant academics, but they are also great fun to work with. They're very inclusive, supportive, and collaborative, which is really truly a winning combination. So I could say much more, but I will leave it to them to showcase their great work. So over to you.
Good morning, everyone. Thank you so much to the organisers for the invite for us to do this. We were reflecting on this was a little daunting to talk to many of our peers and our heroes, but it's an absolute joy to talk about some of our perspectives on behaviour change and the kind of work we do. And we look forward to taking you on a journey of some of the things we've done, although it's always hard to cover everything we've done. But we wanted to tell you about some of the things that we've done. As Fabi said, Lucie and I work together a lot. We don't always work together, but our best work is together. And therefore, in this talk, you're going to be noticing us swapping between us. Lucie and I are looking more similar as we get older. We can't fight it, we've tried. So if you mix us up, we won't mind. And if you don't notice which of us is talking, that's absolutely fine as well. And we will be doing this together and swap a couple of times. The other thing we've noticed this morning, with apologies, is a couple of typos. That's just to show that, like all of us, we make lots of different small errors, hopefully. So apologies for a couple of small typos in there. What we're going to be talking about today is thinking about how we embed behavioural research and practice in complex systems. So we work locally, nationally and internationally, and we try to work within systems. So what is already going on and how can we enhance that with behavioural science, both with directly changing people's behaviour, but also understanding and exploring that through research. We mainly focus on health workers, on health professionals, and we think that is an interesting way to work. I know many of you also work with health workers. We think there's lots of influences we can have, lots of interesting ideas and discussions we can have, and we're going to be talking about that today. We're going to take you on a little journey in our vision of utopia, and we'll come back to that later. Spoiler alert, we haven't quite found utopia yet, but we'll tell you where we've got stuck, and we want all your help to think what to do about it. So here's a little about the way in which we work, and we wanted to set this out at the beginning, that we work in this intersectional way. We think it's really important in the way we think about behavioural science that we are thinking both about research, practice, education, and social responsibility all at the same time. Sometimes funders and higher education institutions and society want us to label which of these things we're doing at which particular time, and our structures really speak to that. But the way in which we think about the world and the way in which we think about behaviour change means that we're trying to work thinking about what research we can do, how we can explore what's going on, at the same time as thinking about what practice we might be able to change, how we might be able to use education and training to get there, and with a very strong focus on our being socially responsible. That's both locally and globally. In fact, we often use the word social accountability instead of social responsibility because we think that in higher education, in academia, in our practice, we should be socially accountable to those around us locally and internationally. So we work in that little spot in the middle of research, social responsibility, and practice and education. The other thing is that we work together. And as Fabi said, that's relatively unusual for people to do a joint keynote, but we wanted to do this together because we work together a lot. We make each other braver. We are each other's critical friends. We're undoubtedly more innovative together. And it's much more fun working together, to be honest, especially when we're traveling the world. We mainly have different strengths and weaknesses, so we balance each other out, apart from one very crucial weakness that we both share, which is directions, which is ironic. But apart from that, we broadly balance each other out. So let me tell you a bit about some of the things that we think are important and that shape what work we do and how we make decisions about the work that we do. The first of these will be very familiar graphs to you in terms of global health inequalities. There's obviously, this isn't the whole picture because within countries and within societies, there's a lot of averaging out here. But if you look at this graph on the left and think about the burden of disease, this is measured in disability adjusted life years, you can see that the colour of the graph broadly is getting darker at the bottom of that graph. There are greater health inequalities in the global south. We use different terms for different areas of the world, and we're not sure that we're very comfortable with any of them. There's people use terms like low and middle income countries, global south, low resource settings. We particularly like thinking about the majority world, that we in Europe are the minority world, what is happening in the majority world, and what is our accountability in those areas of the world and the work we do. You can also see on the right-hand side here a graph of life expectancy, again, very averaged out, and there are great inequalities within high-income countries, but that you can see that Africa is the bottom line on this graph. So we think about where the greatest areas of health inequalities are, and that helps shape where we would like to work and where we would like to contribute. Another really important topic that we've come to focus on over the last few years is antimicrobial resistance. This is described by lots of people as a silent pandemic. It's a huge issue that people aren't always focusing on. And we think when we look at antimicrobial resistance and what we need to do to tackle it internationally, there are so many behaviours as part of that pathway. There are so many things that we as behavioural scientists might be able to advise on and support on to tackle this really crucial international crisis. So now a leading cause of death worldwide, undoubtedly impacting some of those countries more than others. A global analysis in 2019 showed 1.2 million people, potentially millions more, died as a direct result of antibiotic-resistant bacterial infections. The figures by 2030 and 2050 are pretty horrifying. And we're seeing that around us. You might know that in your local context, and you might have heard about it globally. We need to take urgent action to help save lives and protect our health systems, reserve antibiotics for really when they're needed, that we can be sure that they work. Lots of actions, as I said, but include optimizing the use of existing antibiotics, they're used appropriately, and taking greater action to monitor and control infections. So we'll come back to that later in the talk. And then the other thing that drives us and helps us to think about the work that we do and where we might focus is a lack of universal health coverage. And you can see again a graph that shows some disparity across the world. This isn't the whole picture. Many countries are going in the right direction towards universal health coverage. Other countries are going in the reverse direction, where coverage is getting worse. We're obviously, as many people are, very concerned about what universal health coverage looks like, and particularly what health workforce is needed, both in terms of numbers. So very conservative estimates are that by 2030, we'll need 10 million more healthcare workers. Other estimates are much higher than that. So global shortages of healthcare workers, a disparity between countries where some are really well served, some terribly served. How do we increase both the quality and quantity of health workforce? And as behavioural scientists, what role can we play in that so that people are trained in a way that they can serve the populations they need to and tackle the health issues they need to? And I think we can all work towards that. And I know many of you in the room do work towards that. How can we be doing that on a bigger scale? How can we have influence? So Lucie and I, in our university roles, have leadership roles where we're trying to tackle this alongside the behavioural science work, but we think we can do this in a really joined up way in our leadership and practice and education alongside research. So those are some of the things that really worry us, that drive our decision making and how we work. Coming back to behaviour, there was an editorial in a new, as it was at the time, USAID journal, Global Health Science and Practice, which is a good read. And the editor at the time was Jim Shelton. And his opening editorial in this Global Health journal was about behaviour and behaviour change. And this is a quote which I'll read from the editorial. Behaviour is crucial throughout global health interventions. The discipline of behaviour change offers distinct expertise needed across 6 different domains of behaviour. Such expertise is in short supply, however. We will not have effective and sustainable health systems nor achieve our ambitious health goals without seriously addressing behaviour change. It's great to be in a room where that behaviour change expertise is not in short supply, but we're needed in many places around the world. We're needed to support capacity building so that many other people can support through behaviour change. This was a really helpful editorial at the time it came out in 2013. We'll revisit 2013 later, because people started talking about behaviour and behaviour change across these 6 domains in a way that maybe they hadn't thought about how behaviour change could influence across these domains before. These might be familiar to us in the room, but people hadn't necessarily thought about the multiple ways in which behaviour could be influenced through this expertise. The area that Lucie and I and many of others of you in the room focus is that bottom right, so provider behaviour. So what is the behaviour of health workers across many different areas of their practice? And we're going to focus on that now. In case you miss it, I'm now going to swap over to Lucie.
I nearly missed it. That was worth. Okay. So I just wanted to point out, by the way, that the policy picture, which was a bit of a comedy picture that we did once and then forgot to take out when we were doing this talk to a load of policymakers. A little bit offensive right there. So it won't be difficult for people in this room to answer this question, but why are we focusing on provider behaviour? Well, it's because it's really difficult to change provider behaviour. So if 17 years is the answer, what is the question? It's the average time taken for a new innovation to make it into standard practice. It's obviously a ridiculous statistic, by the way, and I know that, but it really shows the point that it's actually really difficult to get people to change what they do in the workplace, in the health workplace, and also that it's really variable. So the hand hygiene one always kind of sticks with me, because we've been trying to influence hand hygiene for centuries, and we're still struggling with that one. And I was contrasting that really with statins, which basically they were only trialing in the 1980s, and now there's massive wide-scale adoption of them. So there's a huge variability in provider behaviour change, but it is quite hard generally. So I wanted to just say about how we live that intersection and how that influences the way that we work. So Joe mentioned about working within systems. So we need to understand what's currently happening within systems. So provider behavior change is one of those behavior change tasks that's not really done by behavioral scientists so much as done by lots of other people as well. And we'll talk about who in a minute. But the fact that you're working in an intersection with educators and trainers and other people interested in provider behaviour means that you need to take a co-development approach. So that sort of drives us in that co-development participatory approach. There's also something really important about the way that people who are not behavioural scientists think about behaviour, but also know stuff about behaviour. And we need to make sure that we have that respect for people's heuristics. So often, we talk about the common sense models as being wrong and that we have to work to address those. But there are also ways of behaving and of working with providers that are probably right. But what we do need to do is have a sort of mutual respect about our science, other people's heuristics and so on. We need to build on what the people already have, capability, opportunity, and motivation to work with providers, and what we need to build on to improve that. And this is something that Robert West said once in a conversation that we were having about how sometimes when you're working within complex systems, your data is a bit rubbish. Basically, it's not, it's hard to get really good, robust data. And I remember Robert saying it's not about the data, it's about how robust the conclusions are that you can make from the data that you've got, and being very clear about that. So that's definitely helped us a lot, but also wanting to make robust studies as well. So how can we work with people to move the way that they conduct their provider behavior change into a more robust way of collecting data and doing research, but also that big focus on making a difference in science and practice. So Joe mentioned Utopia. This is embedded behavioural research Utopia, which is that we're doing rapid trials of interventions to change provider behaviour in the areas of most need where people are currently working. So this is that kind of amazing sort of picture. It's not a new picture. It's not our idea. There's a guy called Ian Chalmers who used to chair something called the James Lind Alliance, which is a sort of patient-led drive to have better trials of everything. And he talked about this, his utopia, which was that we don't currently know which dose of vitamin B12 is better. And his utopia was that every patient who went to be prescribed vitamin B12 would be automatically randomized to receive one of the number of doses that you needed. It was happening all over the world. And so we had huge amounts of data, that the data were then collected, and very, very quickly we'd know what the dose of vitamin B12 would be because of the volume, and therefore we could switch everybody to the correct dose. And because all of the health professionals are involved in it, the whole system, you don't have to then try and convince them to change because they're already involved in the science. And then you just move on to the next randomized control trial. So this is the utopia, but in a behavioral science way, where we actually are looking at systems that already exist to change provider behavior. We're making the data very robust, collecting it, changing, taking on a new topic. Sounds really good, but snakes and ladders. Too many snakes, not enough ladders. So where did we, when we kind of envisioned this utopia, where did we start? Well, we need to start with building relationships and advocating for that kind of work. And that takes us up a certain ladder. And then we can explore what people are currently doing. So really learning from those heuristics, bringing people along with us, working on the problems that they have, and that would take us to the next ladder. Then we could do some prospective studies that explore behaviour. So being able to collect data, looking at the feasibility of working within systems, to collect really good data on provider behaviour, really to explore where we currently are, and that would take us to the intervention studies that we really want to do, so that we can start to draw firmer conclusions from more robust data, and then it would all be functioning, and that would be wonderful. So where do we start with the advocacy and relationships? Well, we needed to look at who was doing provider behaviour change in those global south areas about the kinds of things that we were most concerned about, those really big things like antimicrobial resistance. We'd just by chance, working in a hospital, had done some work with a health partnership, which was a link between the hospital we were working in and a hospital in the north of Uganda. And we did some work with them, and we kind of said to each other, we need to kind of do more of that. And who is basically doing that work? And we got introduced to this charity called the Tropical Health and Education Trust, which basically does health partnerships. So it funds health partnerships, it works with health partnerships. And we literally rang them up and said, you need a bit of behavioural science in your partnerships. And we started to work with them. The reason that we focused in on education and training for provider behaviour change is that that's what everybody was doing. So within the systems in the UK, but within these global health partnerships as well, if people wanted to shift provider behaviour, they were doing education and training. So we thought, okay, so that's probably the place to start, because there are systems in place, all different levels of provider, undergrad, postgrad, CPD, lots of all of these kind of things that providers were engaging in already. Health workers really understand what it is because they've all done it and they know that they have to do it. It's not kind of frightening intervention, it's education training. And organisations also understand what it is and will fund it and so on. So the challenges with that, the flip side of that, is that people think we're talking about education and training, and we're not in either sense, actually. So we're not talking about education and training as the intervention functions in the behaviour change wheel, because they're really specific about behaviour change. And we're not talking about education and training as educators talk about it, which is intended learning outcomes, which is basically capability. So we're kind of somewhere... we're not talking anyone's language. Basically, we're talking about it as a behaviour change intervention that might include loads of different intervention functions and techniques and so on. So that's confusing. The education and training community, and when we do education and training, everyone focuses on competence. So competency building, which if you look at it, is all about the person. It's all about capability. And we know that just because I can doesn't mean I will. And so we're kind of fighting the tide of intended learning outcomes. So that was also a bit of a challenge. The systems being in place is great, but the systems being in place also means you've got to learn to play well with others. That's difficult. Education research, there's very little tradition of high quality education research, so the kind of stuff that we're talking about. So although people are very interested in understanding the impact that their education and training has on provider behaviour, there isn't really very much of a sort of a system or tradition of doing that. So we heard lots of people being aspirational about that, but not actually doing it. And the other thing about working across different countries is this concept of weird psychology, which I'm sure lots of you will be aware of and heard of. Weird stands for Western educated, industrialized, rich and democratic. And most of our populations that we've done most psychological research on up until this point, that is known about by Europeans and studied by Europeans and North Americans, is samples taken from these weird populations. So actually the science itself isn't fully developed in the global majority world. So how applicable is it to the global majority world? So problems. However, 2013, which Joe mentioned earlier on, there was this huge focus on partnerships for health. So lots of governments were funding global health partnerships. So there was a kind of system already that we could think of working with, where there were already people working with people from the UK and other European countries and across those borders. So that was great. Joe mentioned Jim Shelton's commentary in the first edition of Global Health Science and Practice. So behavioural science is crucial. Everybody's kind of listening to that. And then, of course, CBC did this incredible work pulling together the work that they did to make the behaviour change wheel. So all of a sudden we went from, I can't really explain all of these constructs to you, to there's three things and that's it. And you can do the work, but you have a language that you could communicate with other people about. So those kind of three things really led to us being able to start work in this area. So the big question, the first one is, are the people doing education and training doing behavioural science? So we've kind of come along and we've said, it's a way to change people's behaviour. To what extent are they doing that? And that was the first kind of question that we wanted to ask. So we started to work with one of these big organisations that does this kind of work. And this, I'm not going to be able to say it very well because that last word is so difficult, but it's the World Federation of the Societies of Anaesthesiologists. You should never have a name that big. I mean, I can talk obviously with my big name, but it's too big. But they have been doing a 3-day training course globally for many, many years. And they've worked in loads of countries. They've delivered, it's way more than 185 now. And they're basically trying to make anaesthesia in obstetric emergencies safer. And it's particularly designed for low and middle income countries where a lot of the anaesthetic providers are not doctors. So it's kind of safety netting, and it's kind of very, very practical and important in terms of universal health coverage. So we started to do some work with them. One of the things that I'll point out here, which happens all the way through all of the organisations we work with, is that they state in their sort of aims or missions or goals that they want to increase the competence of providers, so to decrease maternal and child mortality and morbidity. That's really interesting because there's a whole middle bit that they haven't articulated. So it's how does somebody go from being competent to an outcome? So where is that part of it? So just a really interesting thing if we're thinking about, are they doing behavioural science at all? So we started, the first thing with them was we said, what practices are you trying to change? So we know that you're trying to improve child and maternal health. But when you do your programme, what do you expect the people who come on the programme to do afterwards that they weren't doing before, or to stop doing that they currently are doing? And so we spoke to the lead first, and she identified 10 behaviours. But she said, you know what, I'm not quite sure. I'd rather go out to my lead faculty countrywide. So we did a small Delphi study with the faculty countrywide, and they identified 15 behaviours, but there was only one that overlapped. So they were actually trying to change 14 behaviours, according to them, and that was just completely confusing. Okay, so we kind of went, oh, this is really interesting. So let's observe some programs, and when the people are delivering the program, what behaviours are they saying that they want people to do? So what are they being explicit about? And so we took those 14 behaviours, and we looked at them again with the ones that we observed, and there was only 8 that overlapped. So actually, the whole faculty, in terms of what they thought they were doing and what they were delivering, actually, they only agreed on 8 of a huge number of behaviours. So that in itself was just absolutely fascinating. So we started to sort of work with them and to think about how we could look at the data they already had, and sort of what robust conclusions could we draw from those data. So we were able to say that they were changing learning. So there was an educational impact because they collected really good data on skills and knowledge, which is what educators do, of course. And we were also able to look at data that they'd got, which would be really hard for a behavioural scientist to get, which is interesting as well, which was observational practice data. So they were sending very expert anaesthetists out to lots of different rural operating theatres and places where women were giving birth, and doing observations of practice that they were able to judge as appropriate or inappropriate, or in line with the training or not in line with the training, which was absolutely brilliant data. And so we were able to kind of do that and look at what behaviours they were looking at there, and what the behavioural influences were that they were noting as well. So this was good. It was some cross-sectional exploration of behaviours and influences, but it was really dependent on what the clinical teams observed, so what they were actually focused on, which we knew wasn't necessarily the same as everybody else thought they should be focused on, and so on. So we thought, wouldn't it be good if we could do some perspective with them? So we did this whole thing again with which behaviours, and we got them to basically select 20, and we thought, well, let's just do a very simple self-report of those 20 behaviours before and after. And then get them to identify the 4 real example, most important behaviours, and do a sort of behavioural analysis of those 4 to look at the behavioural influences. Numbers-wise, just wanted to show you the kinds of numbers that we were dealing with, and because this is very distributed work within a system that's already happening, as we've said. So there were about 361 people that attended the programme altogether in these 4 different countries. Because they're really good at the knowledge and skills bit, the knowledge and skills assessments, almost everybody did. The behavioural bit, we're kind of dropping down to maybe only 50% filling in a questionnaire. I could go on for a long time, very boringly, about Likert scales and whether or not they're okay internationally, but I won't. But people found it difficult to fill in the questionnaires effectively, even though they were mainly translated and some of them were delivered face to face. We then did a post-course thing. We got even fewer of them completing it because they all were busy and went back to work. And then at follow-up, it actually went a little bit higher again because somebody was going out and collecting those data. But we were also able to do a larger number of interviews than we would normally do because it was distributed, and we trained people to be able to do that in those countries. And as I say, the observational stuff was much easier to do because we were working with the anesthesiologists themselves. So just to give you a little flavour of the kind of thing that we did, we looked at time 1, time 2, time 3. This was self-reported behavioural expectation. So if you were faced with that situation 10 times, and how many times do you think you would expect to do that practice? And we had a really big ceiling effect at time 1. So that either, we talked to the people about it, that's either people self-reporting wrongly, or it was because they didn't have to have they shouldn't need the course, basically, which was a tricky conversation to have. But we did see some behaviours that were lower, and those behaviours did show change from time 1, time 2, and time 3. So the course was having a bit of an impact on some of the practices that were self-reported as quite low to begin with. And we also were able to do that triangulation. So we did this large interview study, and we were able to look at cross-referencing those behavioural findings, the questionnaire findings, against some more qualitative data. And the kind of things that were really important were people's opportunity, not surprisingly, physical opportunity. So people were saying, I can't call for help as a behaviour because I'm literally the only person that's there. There aren't more people, so physical resource is a problem. And then there was a really interesting social opportunity, which we find a lot actually all over the place with this kind of work, that the anaesthetists were trained. So this giving the wedge thing is a left lateral tilt. If you're supposed to tilt somebody, if they're having a cesarean section, it gives them better outcomes. But the surgeons didn't want to do it. And because they were non-physician anesthesiologists or anaesthetist providers, they weren't allowed to do what they needed to do by the surgeon who was in charge of the operating room. So there was some really good qualitative stuff we found there. So the SAFE team, if you think about impact, the SAFE team went on to develop a whole operating room course because of that social opportunity barrier to change. So instead of just working on the anaesthetic providers, they brought in the surgeons as well. And then we did some more work writing up those sort of quantitative and qualitative findings around practice change. But where we didn't get to with that organisation was any intervention studies where we could actually change what was delivered in the intervention and see if that had an impact. So we weren't really able to do any behavioural causation type work. There was no appetite for it whatsoever. And the data collection side was so tricky that we felt that we weren't able to do that. I'm going to pass back over to Jo.
So we're going to move on to a different example now. And this is some work we've done in antimicrobial stewardship, which I mentioned antimicrobial resistance at the beginning. And there's been a huge amount of funding in the UK and internationally, appropriately, we feel, in the UK through the Fleming Fund to tackle this globally. So they're funding work globally to enhance appropriate use of antimicrobials and increase surveillance. So what data we have, how are we monitoring this? What is going on, and helping people from that to understand what they might change once they've got that picture of surveillance, training people in how to do that internationally. So there's a number of phases of this work of this programme that's called the Commonwealth Partnerships for Antimicrobial Stewardship. And so a few different phases from March 2019 up until the present day. And there's another round of this work just been funded. In the first couple of rounds, there were 19 partnerships in 8 countries. And then moving forward, there's been 12 partnerships. We anticipate there'll be more. The work that we do as part of this stems from that initial cheeky contact we made to THET and to other organisations saying, do you know what, we think behavioural science, behaviour change theories and principles might help you in some of this work. There's brilliant work going on. It's already happening. We might be able to enhance that. We may be able to help you to understand why something is working, and if it doesn't, why that might be the case, working in all the ways that Lucie's already talking about, education and training being one of those founding areas where people are doing an awful lot of work. So our role across these multiple partnerships, we worked in a number of different ways. So we gave an overall introduction to behavioural science, to the whole of the networks, to all of these partnerships in both the UK and the low resource settings that these partnerships were based in. We had behavioural scientist volunteers, some of which I know are in the room. And this is part of what we've called the Change Exchange, which is where health psychologists and other applied psychologists are joining health partnerships to do whatever the work is they're doing. So they are advising on behaviour change, they're understanding what's going on in the context, they're doing things like interviewing people, barriers and facilitators to change ahead of any intervention development. They're often in the thick of it into what an intervention might look like, and that breadth, including education and training, but beyond education and training, using those principles and the behaviour change wheel to guide those discussions and open up those opportunities for people, and being there to evaluate and carry out robust research where possible. This we have found in the way in which we've worked enhances the partnerships, the staff from the UK and low-income countries to learn about behaviour change and get that appetite for behaviour change. So they are working in a very embedded way as part of these partnerships, with Lucie and I and other colleagues supporting and supervising and trying to enhance that work. We did a lot of training in behavioural methods and tools, so introducing to those concepts. As we've already said, those CBC tools that we have are absolutely vital, very clear, articulated ways of working that people really understand those concepts, and that's been really important and helpful to us in our work. And doing that very specific training in behavioural science. So we've developed CPD modules for pharmacists, for example. We've done some online synchronous training. We've done lots of action learning sets internationally, and we've done drop-in clinics as well. So we're trying to support people with behaviour change and some really difficult, complex concepts, understanding that whilst we think training in behavioural science and these behaviour change theories is really useful, there is a stage at which we need that behavioural science expertise, those people who are trained in the theories and methods and tools and know how to apply them. We think having those behavioural scientists there enhances, develops our cumulative science and keeps us going as a field. So that's the way in which we've been working. Alongside that, we've been able, as part of that work, to do some studies as part of this. So this is this intersection of research, practice, education, social responsibility. So, for example, in this study, we asked 12 health partnerships to send us all their materials. So all of the materials they've used in their interventions. What we did with that was coding the behaviours targeted where we could find it and for behaviour change techniques. And there's been multiple examples of this kind of work before. We were very guided by the Steinmo Sepsis 6 paper and some work that we'd done previously in this area in CPD courses. All of those partnerships that sent us materials that had a half-day training session, 2 out of the 6 partnerships that had a behavioural scientist attached to them. We found lots of BCTs across the partnerships. The biggest one we found, maybe not surprisingly, was instructions on how to perform the behaviour. We found that it was rare to specify the behaviours that they were targeting, thinking back to what Lucie said about the SAFE course and those, is everyone clear on what behaviours they're trying to change, and rare to explicitly match BCTs to behaviours and influences. So that was really helpful to us, and we were able to publish about that work in that small study. It's doing that jumping thing now. It's going to move on. I'm trying to be patient, but I can't. I'll tell you about the next study. So the next study we did as part of this was to interview those behavioural scientists. There we go. Interview some of the behavioural scientists working in these partnerships. So what is their experience of working in these partnerships? How does it feel? We knew how it felt to us and the kind of way in which we'd worked and some of the challenges. We did deductive analysis using NPT. Some of the things that came out were how relationships were really crucial. So that's where we'd started with the relationships and the advocacy, and how being part of these partnerships, so they're part of the team that are traveling, they're part of the evening conversations, the break time conversations, bringing that unique perspective of behavior change, and sometimes seeing things differently, saying, oh, actually, I saw this, or I spoke to this person. This is how it looked to me. And have you thought about this? And have you considered this? Reflection on that was absolutely crucial, both within behavioural scientists, but with the teams more generally. They also described a need to rapidly reflect on how applicable those theories and methods, which we're very familiar with, are to the context, which Lucie talked a little bit about before, that weird science. How applicable is that across the world? And when there is a focus on individuals and we are in a collective culture, how applicable are these theories and methods and measures? And do we understand the full extent of that? So that's the kind of thing that they were talking about. One of the things we're sometimes asked is this just a global health issue? Is this an international issue? What is going on in antimicrobial stewardship elsewhere? And some of our colleagues we work with in low resource settings say, you must have this all sorted in the UK. And we, of course, know in Europe and in the UK, we haven't necessarily got everything sorted. In fact, very little sorted. So this is part of a big piece of work that we did with Fabi, Lauren Cato and colleagues across the UK. And this is one of the studies that we've published about this, that there was an in-depth interview study with people responsible for antimicrobial stewardship and training in UK secondary care. What we found from that was actually very similar, that there was a lot of the materials were locally created, a huge emphasis on knowledge, a lot of PowerPoint slides. Our colleague Rebecca Turner read a lot of PowerPoint slides. She was very patient. But a lot was recreated material, recreated in-depth material, an awful lot in there, not explicitly focusing on behaviour, focused on doing training, knowledge and skills increases. And they really want to evaluate and understand how good that is, but they don't know how to. So very similar findings from our work in the global health partnerships, that actually it's difficult and people aren't necessarily doing it very well. So we think there's a real role in the UK as well as internationally to do this. So not just a global health issue. So a sad story. Here we are in utopia. We've postponed it for the time being. We think we've done some good stuff, but we're a bit stuck at this stage of thinking about intervention studies, how we do those in this embedded research kind of way. So we'll come back to that. But one of the things we've been trying to work on is making behavioural science more accessible. People say, this sounds really relevant. This sounds really important. What can I read? What can I do? How can I learn more about this? And one of our solutions to that has been the cards for change. If you ever want to be popular, publish some cards. The people like them much more than our papers. Health partnerships really wanted to use these BCTs. We talked about them. They're like, how can we use these BCTs? What can we do? Even if they'd read the papers on effective BCTs, which aren't always easy for a non-behavioural scientist to understand and think about how to apply, they weren't sure how to practically use them. We wanted a robust way to use them. So we published these cards for change. And the cards for change look a bit like this. So we created them deliberately to be aesthetically beautiful. So we think that adds to the credibility. They are physical things, which people still really seem to like, although we're really interested in doing a digital version of them. And they're playful, so people feel like they can have fun with them. We deliberately include games as part of the pack. For those of you maybe from the UK who did this a lot when you were young, Top Trumps is one of the games in there. So we were keen that people were playing with them, absorbing and engaging with them. They were co-created between behavioural scientists and for our first set education and training experts. So how could we do this? And we had 43 BCTs that had come out of our previous work in observing education and training that we thought were relevant, and our co-developers thought were relevant. So BCTs with definitions and instructions and games. So that was our first pack of cards. Since then, we've done a number of packs of cards. So we've worked with Public Health Wales on a Help Me Quit version, which is for smoking cessation practitioners, and that's using Susan and Robert's smoking cessation taxonomy. We've published versions which are for health partnerships specifically in both French and English, because lots of the partnerships were in Francophone countries. And we've most recently published a campaigns edition. So we were really interested yesterday to hear Robert talking about campaigns. And what we've done again is work with public health and other experts in campaigns to think, how does this relate? How can we apply the BCTs to campaigns? And again, thinking about examples. So that came out of some of our work with NHS England to make something practical and usable for people who'd been learning about behaviour change to go back to their everyday jobs. How can I use this when I'm designing my next campaign? So we stopped counting, which is terrible, of how many people have requested these packs, but we stopped counting at 280 people had requested the packs, over 25 countries across 5 continents. And we know that 2,400 packs have been distributed across the world as part of these partnerships that we give out as part of our partnership working. And that's been a really interesting thing we did. It was one of those, to be honest, we had a bit of money left at the end of a grant. What shall we do with it kind of things? Possibly one of the best things we've ever done.
Also, we didn't want to do a workshop.
Oh yeah, we didn't want to do a workshop. We didn't want to do another workshop. So we thought, why don't we do this instead? But we think there's something about the concrete, practical, that people feel they've got something they can take away with them, with all of the relevant links to back to the science, back to the evolving. I should say for the campaigns edition, we've been working with the updated version, so BCT ontology version. So that's been great because we've learned about the 281 as it was, and that's really helped. So people like Nia Coop, who's in the room, has taken the lead on that, and it's been absolutely brilliant to do that new version. A lot of fun. So Lucy mentioned earlier around intended learning outcomes, and that has been a bit of a frustration of ours. So people go away with this idea of knowledge and skills. We think there's some tweaking that can be done. So we are suggesting every time we talk to people that they are not just thinking about intended learning outcomes, knowledge and skills, but they're thinking about intended behavioural outcomes. They're thinking about, what do you want people to do differently as a result of this education and training? And that's had some traction with people who understand that concept. And we work with them on thinking about how they develop capability, opportunity, motivation. So not just capability in knowledge and skills, absolutely crucial, but not the whole story. But thinking about including in education and training coping plans, action plans, talking about advocacy and other people, thinking in motivation terms of persuasion, coercion, reducing friction. So that's the way in which we talk about that. And we say this a lot everywhere in the world. Just because I can doesn't mean I will. And that really makes sense to people. They're like, oh yeah, of course. And then you can lead on with all of the other stuff. The last thing I wanted to mention was about a book that we've recently written. I usually say, don't buy the book, please don't buy the book, but we wanted to tell you about it. We don't want you to spend money on it. But we created this for people who kept asking us, how do I use this? As well as the cards, how can I use this? So it's quite a practical guide, how you use behavioural science to develop education and training. And we were delighted that Jim Campbell, who we don't know very well, but we'd like to call a close personal friend, who's Director of Health Workforce for the WHO, read the entire book and wrote an amazing foreword. So he included in that the application of the principles, tools and approach would do much to accelerate the use of behavioural science in the training of the world's health and care workforce, address existing market failures and impact learning practice and patient outcomes. I'll pass back to Lucie for the final bit. Back to Utopia.
Oh, yeah. Okay, so if we think about how we're moving towards that intervention research thing that we were talking about, so we think we're kind of done well with the relationship bit of it-ish. We've done some interesting things to get people to move along with us, but now we're thinking, how do we move towards that intervention research? So we're doing a bit more of what colleagues call using the science. No, yes, using the science to encourage people to use the science. I think that's the thing. So we're exploring through our work with Behavioural Research UK, which Susan mentioned yesterday, which is a consortium for behavioural research leadership in the UK, funded by the Economic and Social Research Council. We're looking at what the barriers are to doing interventional research, and specifically what stops people from going from behavioural research that's embedded, that's exploratory, like the stuff that we've done, exploring and explaining behaviour, and what stops them moving towards being able to intervene with behaviour using a robust method that's high in the hierarchy of evidence, basically. So we're just about to do some studies on that. We also know that people in audit and feedback land are doing this work really well, and it's difficult work, but the implementation laboratory work, which is where you go into a place that's already doing audit and feedback, like a big hospital, and you do rapid head-to-head trials within them. So we've joined their gang and are trying to get them to work with us. So we're working on some protocols with that at the moment, particularly in the AMR global health space. And we are continuing to support global efforts in AMR. CWPAM's, that Commonwealth Pharmacist project, is moving towards phase 3, and we're trying to work on a slightly different model of working with them, where we'd have more dedicated behavioural science expertise. We're also trying to create a centre in our own university, which is challenging because that structure of bringing together education, research and social responsibility just literally doesn't exist in the structures of our university. So if you want to do something research, you go through one route. If you want to do something teaching, go through another route. We're trying to bring those things together. Joe mentioned our leadership roles. That really helps because we're having all those soft conversations, that soft influence that people have, to try and see if we can do that. And just the final thing I wanted to say is that everything strategic ends up the other side. And we thought we'd be at the flag probably 5 years ago. We're nowhere near the flag. I think I'm still in the water, actually. And the other thing we wanted to say is that we work enormously collaboratively with so many different people and so many different organisations that I couldn't possibly thank them all